I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we're talking about uterine fibroids, a condition that affects up to 80% of women. These benign tumours may seem straightforward, but their impact on women's lives is anything but simple. We'll explore the intricate biology behind fibroid development, discuss how they can affect everything from fertility to daily life, and unpack the latest innovations in diagnosis and management. So let's get into it. What is a uterine fibroid?
Fibroids are benign tumours that arise from smooth muscle cells and fibroblasts in the myometrium. They're also known as leiomyomas, which is derived from the Greek words lyo meaning smooth and myo meaning muscle. To the naked eye, fibroids look like round wells of smooth muscle and connective tissue. Fibroids are the most common benign tumours in women, with the prevalence of about 25%. They become more common with age, affecting up to 80% of women by the age of 50. Interestingly, they often shrink after menopause or childbirth.
So how does a fibroid develop?
Fibroids are monoclonal tumours, which means that they originate from a single cell that has undergone genetic mutations causing it to grow and divide in an uncontrolled way. There are certain inherited mutations in the fumarate hydratase gene, which is linked to the development of fibroids. These mutations lead to the clonal expansion of a single cell, transforming normal myocytes into abnormal ones, which then grow into tumours. On a molecular level, there is also altered expression of angiogenic growth factors like vascular endothelial growth factor, endothelial growth factor, and tumour growth factor beta. These growth factors cause abnormal proliferation of surrounding blood vessels and increased levels of estrogen and progesterone receptors compared to normal myometrium. This is one of the reasons why fibroids are responsive to hormones. They grow during the reproductive years and shrink after menopause when levels of estrogen and progesterone drop. The median growth rate of fibroids is about 9% over 6 months.
So what makes these mutations happen? Is there anyone who is at increased risk of developing fibroids?
Well, since fibroids affect 80% of women, just having a uterus seems to be a big risk factor. The most common risk factor is actually ethnicity. Black women are much more likely to develop fibroids than white women, with an incidence of 80% compared to 70% in white women. Other risk factors include younger age at menarche, lower parity, family history of fibroids, an increased BMI, hypertension, type 2 diabetes, reduction in physical exercise, a high consumption of red meat, and prenatal exposure to DES.
Okay, slight tangent here. DES stands for diethylstilbestrol, which I just practiced how to pronounce many times, and is a synthetic form of estrogen. It was prescribed to women from the 1940s to early 1970s to try and prevent miscarriage and other pregnancy-related complications. Unfortunately, those exposed to DES in utero are at higher risk of rare cancers of the vagina and cervix and have a higher rate of congenital anomalies of the female reproductive tract. Because of this, DES is absolutely not used anymore. We might go into DES in more detail in a future episode, but for now, back to fibroids. Are there any factors that might reduce the risk of a woman developing fibroids?
So, protective factors include childbearing, prolonged breastfeeding, long-term use of the oral contraceptive pill, Depo-Provera, or an IUD, regular exercise, consumption of green vegetables, and dare I say it, smoking. I'm not sure why green vegetables in particular, but it's a protective factor. So there you go.
So now that we know what fibroids are and how they form, we need to talk about how we classify fibroids. Fibroids are classified based on their location in the myometrium and are usually given a number from 0 to 8. This forms part of the FIGO classification system, which we'll put a picture on one of our summary Instagram slides. The simplified version is that fibroids can be classified as submucosal, meaning they are just underneath the endometrium and they distort it. Intramural, meaning they are deep within the wall of the uterus. And subserosal, meaning they protrude out underneath the outside of the uterus or under the uterine serosa.
Submucosal fibroids are classified as FIGO types 0, 1, or 2. Type 0 is a pedunculated fibroid that sits exclusively in the endometrial cavity. Type 1 has less than 50% of the fibroid in the wall of the uterus, and type 2 has more than 50% of the fibroid within the wall of the uterus. These are the types of fibroids that most commonly cause difficulties with fertility or heavy periods, and they're often visible on hysteroscopy. Intramural fibroids are classified as FIGO types 3, 4, and 5. These fibroids develop within the body of the myometrium and range from contacting the endometrium to being completely intramural or subserosal with more than 50% intramural. Intramural fibroids are typically not seen on hysteroscopy but are clearly visible on ultrasound. Subserosal fibroids form on the outside of the uterus, beneath the uterine serosa, and can be less than 50% intramural, type 6, or pedunculated, type 7. These types of fibroids are clearly visible on laparoscopy or macroscopic inspection of the removed uterus. Any other fibroid is considered to be a type 8. This includes cervical fibroids or other fibroids in weird and wonderful places, like the broad ligament, for example.
When we're talking about fibroids, the size, location, and type of fibroid are absolutely crucial. They significantly influence the symptoms patients experience, they can affect fertility and pregnancy outcomes, and they can determine the appropriate management approach. So on that note, what kind of symptoms would a patient with fibroids experience?
Ranscog just loves asking what symptoms fibroids can cause and the pathophysiologic mechanism behind those symptoms. Abnormal uterine bleeding is one of the most common symptoms of fibroids. Submucosal fibroids increase the surface area of the endometrium, which can obviously increase the amount of bleeding a woman experiences. But even intramural fibroids can cause abnormal bleeding. This is usually due to altered uterine contractility. I guess if you think about it, there's a mass in the middle of a muscle, which is bound to impact how it contracts to cease bleeding. This altered contractility also influences the pain associated with fibroids. If you remember what Carla said before, the development of fibroids is associated with the release of angiogenic growth factors, which causes increased vascularity around the fibroids, which also leads to abnormal bleeding.
The next most common symptom of fibroids are pressure symptoms. These are due to mass effect from either a particularly large fibroid in a specific location or secondary to an enlarged multifibroid uterus. Pressure symptoms include problems urinating or defecating, which are typically due to compression. Patients might experience difficulty voiding or passing stool, incontinence, urinary retention, frequency, urgency or back pain, and lower abdominal pressure. Fibroids can even increase the risk of thromboembolic events due to the pressure of the fibroid on pelvic vasculature, causing venous compression.
Fertility and pregnancy are another major concern or symptom of fibroids. So much so that there is a Ranscog guideline called Fibroids in Infertility. Fibroids can distort the uterine cavity, increasing the risk of miscarriage. The cavity distortion can also increase the rate of malpresentation and surgical complications in pregnancy. The fibroids can alter the overlying endometrium, which may lead to intrauterine growth restriction, and changes in uterine contractility may lead to postpartum hemorrhage, preterm labour, and caesarean section.
While pain is not a common feature of fibroids, women may experience painful periods due to altered uterine contractility. Pain may also be caused by fibroid degeneration. Now, I'm sure you're all wondering what fibroid degeneration is. Well, when a fibroid outgrows its own blood supply, it can cause necrosis and breakdown of the fibroid tissue. It releases inflammatory cells into the fibroid, hence the term red degeneration. Red for inflammation. The other form of fibroid degeneration is called hyaline or cystic degeneration, when spaces form within the fibroids. Fibroids grow in the presence of high estrogen levels and are thus more likely to degenerate during periods of rapid growth, such as pregnancy. Fibroid degeneration tends to have a typical symptom pattern. The pain is associated with a low-grade fever, tenderness over the degenerating fibroid with a raised white cell count. There may be localized signs of peritonism. The pain usually lasts from a few days to a few weeks. Pain could also be due to torsion of a pedunculated fibroid. Pretty self-explanatory. When a pedunculated fibroid twists along its stalk, cutting off its blood supply, it can also cause pain.
The other common feature of fibroids that people are concerned about is the risk of malignant transformation. Now, this is actually a common misconception. Benign fibroids do not transform into cancers like leiomyosarcoma, but leiomyosarcoma might initially present with what looks like a benign fibroid. The chance of this is well below 1%, and so most women should be reassured that their fibroid is not going to turn into a cancer.
Okay, summary. Let's summarize what we've learned so far. A fibroid is a benign monoclonal tumor of smooth muscle and fibroblasts of the myometrium. Fibroids are the most common benign tumor in women with a prevalence of approximately 25%, and they occur in up to 80% of women by age 50. They are caused by clonal expansion of a single cell due to a genetic mutation, usually in the fumarate gene, and they're associated with increased vascularity due to growth factors.
Risk factors include Black ethnicity, younger age at menarche, reduced parity, a family history of fibroids, increased BMI, hypertension, type 2 diabetes, reduced physical exercise, high consumption of red meat, prenatal exposure to DES. And protective factors include childbearing, prolonged breastfeeding, smoking, long-term use of the oral contraceptive pill Depo-Provera or Mirena, exercise, and consumption of green veggies.
Fibroids are classified according to the FIGO classification system and may be submucosal, intramural, subserosal, or other. Fibroids are typically given a type 0 to 8 classification depending on their location. The location of the fibroids may be associated with their symptoms, which include abnormal uterine bleeding, pressure symptoms, infertility or pregnancy complications, and pain.
Okay, so let's move on to the workup of a woman with fibroids. In the history, we want to know the pattern and the amount of bleeding, if they have symptoms of anemia, or any intermenstrual or postcoital bleeding. In someone with pressure symptoms, we can ask about urinary frequency, retention, and constipation. Do they have any difficulty passing urine or bowel motions, or a sensation of pressure in the abdomen? Pain can be dysmenorrhea or dyspareunia, or the localized pain associated with degeneration. She may also have infertility or a history of obstetric complications, like preterm birth, malpresentation, or a PPH. We want to ask about risk factors of sarcoma, including age, being postmenopausal, Black ethnicity, being on tamoxifen, or having a history of radiation.
Now remember, when we are looking for risk factors for malignancy, we are just trying to make sure that what we are dealing with are benign fibroids and not a uterine sarcoma. Fibroids are not precursors for leiomyosarcoma, but uterine sarcomas can often be mistaken for fibroids. We don't want to get caught out with the wrong diagnosis. Keep in mind, though, that the chance of a fibroid being a sarcoma is actually less than 0.2%.
Examination findings include a height, weight, and BMI. An abdominal and bimanual examination are done to assess for the size, contour, and mobility of the uterus. A bimanual examination is especially important for fibroids. It really helps give us an indication of how we're going to treat these fibroids. If a patient needs a hysterectomy, for example, it can be really useful to know that the uterine fundus extends above the level of the umbilicus. This might mean the difference between a laparoscopic hysterectomy, an abdominal hysterectomy with a transverse incision, or an abdominal hysterectomy with a vertical midline incision. A speculum may identify a prolapse submucosal fibroid coming through the cervical os, or a cervical fibroid.
Key investigations are the same as that of heavy menstrual bleeding and include a full blood count, plus or minus a ferritin and a beta-HCG. You don't really need additional investigations like a TSH or a coagulation studies unless there are other features in the history that suggest a need for these. Imaging includes a transabdominal and transvaginal ultrasound and endometrial sampling if there's concern about malignancy. Other options like saline infusion sonography, hysteroscopy, and an MRI can also be useful in the workup or helpful to distinguish a suspected leiomyosarcoma. We'll go into leiomyosarcoma in next week's episode, but for now, a few features that might make you suspicious for a sarcoma include a solitary uterine mass with poorly circumscribed borders, absence of calcifications or presence of necrosis, a new mass or growth during menopause, the presence of intralesional hemorrhage, and abnormal lymph nodes.
Like everything in ONG, management can be conservative, medical, or surgical. The optimal management choice depends on patient preference, fibroid size, symptoms, fertility preferences, and possible concern for malignancy. Conservative management may be suitable for those with asymptomatic fibroids and involves monitoring the fibroids with ultrasound. However, there is no consensus as to the optimal regime for surveillance. In general, if a patient is asymptomatic, they don't actually need any treatment just because you incidentally found a fibroid. Medical treatment involves non-hormonal treatment like iron supplementation for anemia or tranexamic acid or non-steroidal anti-inflammatories for pain or bleeding. And then there's hormonal management.
There are several different types of hormonal therapy to treat fibroids. First, you've got your stock standard combined oral contraceptive pill. Next, we'll discuss the different progesterone-based treatments, including the progesterone-only pill, the oral progesterone such as norethisterone or Provera, the Implanon, the Depo-Provera, and the Mirena. These all offer significant benefits for managing fibroids. These treatments help reduce heavy menstrual bleeding by thinning the endometrial lining, often resulting in lighter periods or amenorrhea. This reduction in bleeding also alleviates menstrual pain. The progesterone-only pill, Implanon, and Depo-Provera work systemically to provide these effects, while the Mirena delivers hormones directly to the uterus for more localized relief. Additionally, these treatments promote endometrial atrophy, further aiding in symptom management. By decreasing the amount and frequency of menstrual bleeding and stabilizing the endometrial lining, these progesterone-based options can significantly improve the quality of life for women suffering from fibroid-related heavy bleeding and pain. With a reduction in bleeding, patients are less likely to have symptomatic anemia or require regular iron infusions. Important to note is that these treatments do not actually shrink the fibroids, but they treat some of the associated symptoms. Also, a huge benefit is that most of these are contraceptives, although not so useful in those planning a pregnancy.
Wait, can you actually use the Mirena for women with fibroids? Like, won't it just fall out?
Well, there is a higher rate of expulsion of the Mirena in someone with fibroids, particularly submucosal fibroids, and studies that reviewed the efficacy of the Mirena were limited to uteri less than 12 week size. So we don't have very good evidence for the Mirena in larger uteruses. But overall, the Mirena does seem to be the most effective at reducing fibroid-related bleeding versus the other progestin therapies. The Mirena may not be very effective in women with submucosal fibroids, which distort the uterine cavity, though. But if there is only a small amount of cavity distortion, then it may still be worth trying Mirena.
I often hear Zoladex being thrown around at work for fibroids. What does that do?
Ooh, GnRH agonists such as goserelin or trade name Zoladex are effective in treating fibroids by temporarily suppressing ovarian function. This reduces the circulating estrogens, leading to amenorrhea and shrinking fibroids by approximately 36%. However, it is essentially a medically induced menopause. The hypoestrogenic side effects, such as bone loss and menopausal symptoms, limit long-term use. GnRH agonists are most commonly used to shrink fibroids before surgical management. Shrinking the fibroids reduces preoperative anemia and intraoperative blood loss. They also increase the likelihood of less invasive surgical approaches, such as a transverse rather than midline incision, and vaginal or laparoscopic rather than abdominal hysterectomies. They also decrease the volume of distending mediums, operative time, and the risk of hysteroscopic treatment failure. To mitigate the risks of long-term use, add-back menopausal hormone therapy, like tibolone, can be considered to maintain bone mineral density and manage vasomotor symptoms. Zoladex is a subdermal implant in doses of 3.6 milligrams for 1 month or 10.8 milligrams for 3 months. In someone choosing this option, say prior to a hysterectomy, you would often use the 1-month dose, see how they tolerate the side effects, and if they do, then consider the higher dose. Because of the side effects, it is generally only recommended to use it as a short-term therapy. For example, the 9 months prior to surgery. There is rapid regrowth of the fibroids once ceased.
You can actually get away with just 3 months of Zoladex use, but typically somewhere between 3 and 9 months would be effective. Aren't there some other random medical options that we can use to treat fibroids? I thought I've heard of a few other treatment options in the past.
There are a few medical therapies which have been used to treat fibroids in the past, but they're no longer recommended because they're either ineffective or they have safety concerns. These include mifepristone, ulipristal, danazol, and gestrinone. Ulipristal treats fibroids by blocking progesterone receptors in the endometrium and myometrium. This inhibits ovulation and cell proliferation, leading to apoptosis. Clinical trials have demonstrated its effectiveness. This treatment was particularly effective for rapidly controlling heavy menstrual bleeding, with 70% of users developing amenorrhea. However, ulipristal has been withdrawn from the market due to concerns about liver injury. Mifepristone treats fibroids by modulating progesterone receptors at a dosage of 5 to 10 milligrams daily for 3 to 6 months. It effectively reduces heavy menstrual bleeding and reduces the uterine volume by 26 to 74%. Compared to GnRH agonists, mifepristone results in slower regrowth of fibroids, making it a potentially advantageous treatment. However, its use is currently limited to research settings. Androgenic steroids, including danazol and gestrinone, have been studied in a very small series, and there's limited evidence for aromatase inhibitors such as letrozole or selective estrogen reuptake modulators like raloxifene.
I've heard of this new medication as well called Ryeco that can be used to treat fibroids. I think I remember it was like a combination of relugolix, estradiol, and norethindrone.
Yeah, so Ryeco is a combination medication that can be used to treat uterine fibroids with mild to moderate symptoms and also for endometriosis. The relugolix is a GnRH receptor antagonist. It is essentially used for ovarian suppression, similar to Zoladex, but with the benefit of add-back estrogen and progesterone. A DEXA scan to monitor bone mineral density is recommended in those using Ryeco for more than 12 months. In those who have a history of osteopenia or osteoporosis or who have risk factors for this, then a DEXA scan is actually recommended before starting treatment. Interestingly, Ryeco can also be used as a contraceptive, but you do need to take it for at least a month before it's considered effective.
Okay, righto, let's summarize our medical options. Non-hormonal options include tranexamic acid, NSAIDs, and iron supplementation. Hormonal options include the combined oral contraceptive pill, progesterone-only options such as the mini pill, Provera, norethisterone, and Depo-Provera, and the Implanon and the Mirena. GnRH analogues such as goserelin, otherwise known as Zoladex, and Ryeco. Options that we don't recommend include mifepristone, ulipristal acetate, danazol, and gestrinone. So let's move on to surgical options.
Procedural options for the treatment of uterine fibroids include uterine artery embolization, myomectomy, and hysterectomy. Let's start with myomectomy. Myomectomy just means excision of fibroids, and it can be done hysteroscopically, laparoscopically, or with abdominal or open surgery. Hysteroscopic myomectomy is minimally invasive and ideal for removing submucosal fibroids. It improves symptoms and fertility outcomes. Laparoscopic or abdominal myomectomy is suitable for larger or multiple fibroids in women who wish to preserve their fertility, their uterus, and it offers significant symptom relief with a higher recurrence rate. Hysterectomy, the definitive cure, is recommended for women who have completed childbearing and seek a permanent solution. Each surgical approach is tailored to the patient's symptoms, fibroid characteristics, and reproductive goals.
Okay, so let's go through each one so I know what to discuss with patients. A hysteroscopic myomectomy is a surgical procedure primarily used to remove the intracavitary component of submucosal fibroids. It's suitable for FIGO types 0, 1, and 2, particularly those under 3 to 5 centimeters in diameter. This procedure can significantly improve fertility outcomes and has a rapid recovery and low complication rate. Some places even perform this as an outpatient procedure. A hysteroscopic myomectomy can be done with a resectoscope or with a MyoSure device. It's considered safe for future pregnancies with minimal risk of uterine rupture. The treatment is effective in reducing heavy menstrual bleeding in 80% of patients and enhances fertility by 40 to 60%. However, there is a 10% risk of requiring secondary treatment within 2 years, increasing to 30% within 5 years. To optimize outcomes, a staged approach and pre-treatment with a GnRH analog, like Zoladex, may be considered. Combining hysteroscopic myomectomy with endometrial ablation or the insertion of a Mirena device can further improve results. While the procedure has a low complication rate of only 1 to 2%, potential risks include hyponatremic fluid overload, uterine perforation, hemorrhage, and infection.
A laparoscopic or open myomectomy can be used to resect larger fibroids or those that are intramural or subserosal. This procedure can involve a reasonable amount of blood loss, so it's important to take considerations to reduce the risk of this happening. Preoperative considerations to reduce the fibroid size or expected blood loss may include a uterine artery embolization or treatment with GnRH analogues such as Zoladex. Options to reduce blood loss intraoperatively include the use of vasopressin, where you inject this directly into the fibroid itself, misoprostol, tranexamic acid, a pericervical tourniquet, or the use of FlowSeal. A myomectomy is very effective, with more than 80% improvement in heavy menstrual bleeding. Recurrence of fibroids, however, after a myomectomy is common, and it rates at about 62% in the next 5 years. It has a comparable surgical morbidity to hysterectomy. Complications of a myomectomy include hemorrhage, hysterectomy, infection, organ damage, and adhesions. If the procedure is conducted laparoscopically, then the fibroids may need to be morcellated, which poses a risk of seeding, organ injury, and parasitic fibroids.
What is morcellation?
Morcellation is a surgical technique used to break down larger tissues into smaller pieces for removal through tiny holes, such as minimally invasive procedures like laparoscopy. It's a machine that essentially chomps the tissue into smaller pieces. This method is commonly used during laparoscopic or robotic-assisted surgeries to facilitate the removal of large fibroids or an enlarged uterus through small incisions, thus minimizing surgical trauma and recovery time. However, with morcellation, there is the risk of spreading undiagnosed malignant tissues such as uterine sarcomas within the abdominal cavity. To mitigate these risks, techniques like contained morcellation within a bag are required. In 2020, the TGA actually stated that power morcellators can only be used within a tissue containment system. It is typically avoided in patients with a high risk of malignancy as well. Morcellation can significantly reduce the need for more invasive surgical procedures, leading to quicker recovery and less postoperative pain. Now, there are some risks associated with power morcellation that do need to be discussed with the patient if this is the planned method of tissue extraction. In particular, the risk of organ injury from the morcellator, including bowel, bladder, blood vessels, or other pelvic organs. Because the specimen is dissected into smaller segments, there can also be difficulties with the histological diagnosis with the loss of anatomical relationships. So this brings us to our next surgical option, a hysterectomy.
A hysterectomy is a definitive cure for women who have completed childbearing. It's cost-effective and has high satisfaction rates. If a patient decides on a hysterectomy, the main consideration is the route of hysterectomy. An abdominal hysterectomy is often required in those with a significantly enlarged uterus. There are significant advantages of a laparoscopic hysterectomy, including a quicker recovery, less postoperative pain, and less risk of postoperative complications. Difficulties of a laparoscopy with a fibroid uterus include access to complete the procedure and difficulty removing the specimen. Methods to make this possible include morcellation, like we've already discussed, and the use of a preoperative GnRH agonist. As we've mentioned, a GnRH agonist such as Zoladex can be used for the 3 to 9 months prior to a planned hysterectomy to improve anemia and shrink fibroids.
Uterine artery embolization is another procedural treatment. What do we know about uterine artery embolization?
So, uterine artery embolization is a minimally invasive procedure used to treat symptomatic fibroids. The process involves the selective catheterization of the uterine arteries through the femoral arteries, followed by the injection of particles to embolize the uterine vascular bed. This leads to ischemia in the fibroids, causing necrosis and subsequent shrinkage, while allowing the normal myometrium to recover through collateral circulation. The procedure is performed under local anesthetic, and patients typically stay in the hospital overnight for pain management with opioids. That's it. Uterine artery embolization results in an 80 to 90% improvement in pain and pressure symptoms and a 50 to 90% reduction in heavy menstrual bleeding, with fibroid shrinkage being gradual and progressive, reaching about 60% reduction at 6 months. However, 30% of patients do require a further procedure within 5 years because of ongoing symptoms. Contraindications for uterine artery embolization include asymptomatic fibroids, current or recent pelvic infection, current pregnancy, and suspected uterine malignancy. Caution is also advised for large submucosal fibroids, as they may detach and cause obstruction or sepsis, and for pedunculated fibroids, which may require surgical retrieval if they detach. It's crucial to investigate any bleeding irregularities before uterine artery embolization, especially in postmenopausal women, due to the risk of malignancy. A uterine artery embolization is not recommended in those who haven't finished childbearing because its impact on fertility remains uncertain, and there's limited high-quality data available in this area.
Complications of a uterine artery embolization, or UAE, can be minor, occurring in 30 to 40% of cases, or major, occurring in 5% of cases. Common complications include discharge and fevers, UAE failure, and post-embolization syndrome. Procedural risks include groin hematoma, arterial thrombus, pseudoaneurysm, contrast reaction, and vasovagal responses. Early complications occurring within the first 30 days include post-embolization syndrome, vaginal discharge, pelvic infection, fistula, venous thromboembolism, sepsis, and hysterectomy.
Wait, what's post-embolization syndrome?
Post-embolization syndrome, which affects about 16 to 18% of patients, is characterized by fever, nausea, pain, and malaise. It typically resolves within 10 to 14 days with rest, hydration, NSAIDs, and VT prophylaxis. Late complications of UAE include ovarian failure, reintervention, and an increased risk of miscarriage, as well as fibroid expulsion.
When considering uterine artery embolization for patients desiring future fertility, caution is necessary as the procedure does not improve fertility and may in fact worsen it. This could occur by reducing ovarian reserve and endometrial volume, potentially affecting implantation. The live birth rate after uterine artery embolization is about 60%, compared to 78% with myomectomy. Additionally, UAE may increase the rates of caesarean section, postpartum hemorrhage, and miscarriage without significant differences in preterm birth, malpresentation, or intrauterine growth restriction.
Now, I wanted to tell you about another minimally invasive treatment, MR-guided focused ultrasound, or Mr. GFUS, as Mel loves calling it. Now, this is not available universally, and I think there's only one centre in Melbourne, which may or may not still offer it because it's pretty costly. Since it's not readily available, it's not a treatment option that I would routinely offer my patients, but it's definitely important to be aware of. MR-GFUS uses MR-focused energy to induce coagulative necrosis of fibroids. It uses waves of ultrasound energy through the abdominal wall. Each fibroid is targeted individually, and it's done as an outpatient procedure with sedation. The pros include a 50 to 80% symptomatic improvement within the first 3 months, short-term morbidity is low, there's a quick recovery, and it's minimally invasive. The cons of Mr. GFUS include that it's costly, time-consuming, contraindicated in those planning fertility, and it's only used in a research setting, and it can't be used for fibroids close to other organs. Some of the risks associated with this procedure include skin burns, nerve injury, reintervention, a 30% failure rate, and damage to surrounding organs.
Okay, let's go through a short summary of the treatment options, which order to approach them in, from least to most invasive, and which ones to use for those who have completed their family and those who want to preserve their fertility. So, in those not trying for a pregnancy, first-line management includes non-hormonal options like TXA and Ponstan, and hormonal options like the combined oral contraceptive pill and other progestins like the Mirena. If there are submucosal fibroids, then a hysteroscopic myomectomy with or without an endometrial ablation, with or without a Mirena. Other second-line therapies for those with fibroids other than submucosal include a uterine artery embolization, and third-line options include a hysterectomy. For those wanting to preserve their fertility, first-line treatments include tranexamic acid and NSAIDs. Second-line therapies include a hysteroscopic or laparoscopic myomectomy, and third-line options include an open myomectomy. The Ranscott guideline called Fibroids of Infertility, although at the moment it's due for an update, has some specific discussion and recommendations. They discuss that the optimal imaging techniques for excluding cavity involvement include an MRI, a sonohysterography or hysteroscopy, noting that hysteroscopies may underrepresent submucosal fibroids because of the intrauterine pressure used. Subserosal fibroids do not appear to have an effect on fertility outcomes. Intramural fibroids may be associated with reduced fertility and an increased miscarriage rate. However, there's insufficient evidence to determine whether myomectomy improves fertility outcomes. Submucosal fibroids are associated with reduced fertility and an increased miscarriage rate. And hysteroscopic myomectomy for submucosal fibroids is likely to improve fertility outcomes.
From the Ranscott guidelines, there are a few indications for myomectomy in infertile women. These include infertile women and those undergoing assisted reproductive technology who have submucosal fibroids, infertile women with symptomatic fibroids, although there is no clear fertility benefit, the symptoms justify the intervention, and couples presenting with multiple failed ART cycles where the female partner has intramural fibroids.
This has been such an interesting topic to discuss. So let's go through some short cases with possible management plans to put some of that information into practice. Case 1 is Sarah. Sarah is a 41-year-old who presented to the emergency department with symptomatic anemia and a hemoglobin of 40. A pelvic ultrasound demonstrated an enlarged uterus at 800 mils with a 10-centimeter fibroid. She's not planning future pregnancies. Her CST is not up to date. She's had 2 blood transfusions and was discharged. Unfortunately, she was lost to follow-up to the gynecology clinic, but she returned 2 months later, again with symptomatic anemia with a hemoglobin of 43. Her uterus is palpable 4 centimeters above the umbilicus. A repeat pelvic ultrasound demonstrated that the uterus was now 1,800 mils. The fibroid had increased to 18 centimeters. The patient wants a hysterectomy. What should we do with her?
Okay, a brief management plan. First, we need to optimize her current hemoglobin with a blood transfusion or 2 and an iron infusion. We need to update her CST and do a Propel if we can. We should arrange bloods for renal function and iron studies. The size of the uterus can cause ureteric compression and even impaired renal function. Because of the rapid growth of the fibroid, we should arrange further imaging with either a CT abdo-pelvis or an MRI pelvis or both. An MRI might be more useful in assessing for features of leiomyosarcoma. In the interim, we can consider the use of tranexamic acid, Primalo, and Zoladex. If there are no signs of a possible malignancy on imaging, then we should plan a hysterectomy. Given the size of the uterus, she'll likely require an abdominal hysterectomy.
Beautiful. So case 2. Sandra is a 35-year-old female with heavy menstrual bleeding and is being seen at the gynecology clinic. She is unsure about her future fertility plans. Her uterus is not palpable abdominally, and on examination, it feels like it's about 10 to 12 weeks in size. Her hemoglobin and cervical screening tests are normal, and her ultrasound demonstrates a bulky, multifibroid uterus with multiple small intramural fibroids. What would you do for Sandra?
Well, you would discuss mostly medical options with the patient. Hormonal options include the Mirena, the combined oral contraceptive pill, or oral progestins. Non-hormonal options include tranexamic acid and NSAIDs, and you would want to make sure her iron studies are normal or arrange iron supplementation. So, case 3. Hannah is a 31-year-old who's been trying for a pregnancy for 3 years. She has a 3-centimeter submucosal fibroid.
So for Hannah, I would firstly discuss medical management of her symptoms, including tranexamic acid and NSAIDs. We'd obviously want to avoid hormonal options since she's currently trying to conceive. Now, we know that submucosal fibroids are associated with subfertility, and so for Hannah, I would definitely discuss a hysteroscopic myomectomy to improve her fertility chances.
And that's a wrap for today's episode. I hope you found this deep dive into fibroids informative and helpful.
Don't forget to subscribe and leave us a review. If you have any questions or topics you'd like us to cover, reach out to us on social media or through our website.
As usual, you'll find our summary slides and quiz on Instagram later in the week. Find us on socials at The Uterine Sound, our website www.theuterinesound.com, or email us at theuterinesound@gmail.com.